many of you may not have the RMA status, which is necessary to get the opioids like morphine, fentanyl, etc. Actually, we should know how can we get RMA status. What are the requirements for RMA status? Rajagopal sir will be talking more about opioid availability, and I'm sure he doesn't need any introduction. Sir, it's over to you.
Thank you, Sunil. Friends, we have been talking so far about medicine, pain, symptom control, psychosocial support, etc., etc. And today's subject is going to be very different. But before I go on to that, let us make this very clear. Whatever we are going to say is aimed at just one thing: relief from serious health-related suffering in the country. Together, this group is going to work towards taking away a bit of the suffering from the country. And numerous people like this joining hands do achieve a lot. So that's the objective. Now, we also know that to achieve that goal, you need a policy, including the government's policy, but also your personal policy, your institution's policy. You are accepting that you are undertaking the responsibility to treat needless pain and suffering. You also needed the education, and that's what is partly achieved by this course. This is only an online course. It has not given you the practical hands-on experience. Nevertheless, we will have to overcome that with repeated sessions, which I am sure Raju will organize as time goes on. When you feel like, okay, I have these doubts, how shall we tackle them? That continued education must happen. We all keep asking consultants from various parts of the world, from within the country, when we are in doubt, hey, we have a person with this problem. Anybody experience? And we learn. So policy education, and the third thing that has to come into place is availability of essential medicines. To repeat, to clarify a little more, availability of essential medicines which are affordable. Affordability is a big issue in our country, and so let us make sure that we keep that in mind. So with that, I am going to share my screen and start on the subject that we are beginning to, we plan to talk about, opening with the statement. Oh, not this one, sorry. Once more. Beginning with the statement that there are 10 million people, or at least seven, this is, I am quoting from the Lancet Commission report, the 7 million they calculated with 20 conditions. There are many more which need palliative care, and therefore it's likely to be closer to 10 million. A crore of people in India are likely to be in suffering with their families. And to remind ourselves, the doctor's duty is to mitigate suffering, to cure sometimes, relieve often, and to comfort always. And there exists no exception to this principle. But if we are going to relieve pain, and when we are talking about health-related suffering and I talk about pain, the relevance is very clearly, pain is one of the commonest symptoms. Is there any other reason? when someone is pain, there is no space for anything else. People try to counsel people rolling in pain. They can't, they have no mind space to take on anything else. Now, all of you have always used non-opioids and adjuvants. This has always been done. Maybe now you will be able to use it a little more effectively than you have so far been able to use, and a little more safely and effectively. Uh, just to make sure that we are okay with that, would you like to type out in the chat box what do you think the minimum dose of paracetamol should be for pain relief? Milligram per kg? Raju, will you read out as it comes? How many milligrams per day? Milligrams per kilogram? Not per day. Sorry, milligrams per kilogram per dose? Minimum?
10 to 12 milligram per kilogram. Dr. Anuj Dubey.
10 is inadequate, doctor. At least 12. Let's start with 12. Maybe going a little over up to 15 may be okay, but at least 12. And how many times a day?
Four times.
4 times. Three times is not enough. Very good. I mean, this is the foundation, non-opioids. Wait a minute. Suppose, say, for somebody with a lot of difficult pain, like a bone metastasis, you want to use non-steroidal anti-inflammatory medicines other than paracetamol. The three most important adverse effects you will bear in mind are: one, gastrotoxicity. It is safer always to give a gastroprotectant. Two, renal dysfunction. Look for pre-existing renal function, ensure hydration. If hydration is not possible, don't take it. And third, in conditions associated with hemorrhage, it's not safe. So non-opioids are what you start with. We also talked about several adjuvants. I will not go into that. But this forms the foundation. Majority of people with severe pain will need more than this. We still use this. Let's have that very clear. Even when we are using a morphine, we usually continue our foundation measures. But this is not the ladder. What I'm going to say is the biggest reason for pain relief in the community will be by what Shashigala and her husband do, or like what many of you will do, integrated into your routine practice. Even if you are not becoming a full-time palliative care doctor, if you are treating a patient, these principles come in. This is going to be the major factor which will remove pain from the community. It would be judicious use of step 2 opioids like tramadol, or strong opioids like morphine, and only those that Shashi and her husband, rheumatologist, practice palliative care along with their routine practice. But then you come across a patient in whom you are unable to treat the pain, and then you send it to a dedicated palliative care unit if you are unable to handle it. So, why did they show this picture? I showed this picture because opioids are necessary even if you are not running a dedicated palliative care unit. Opioids like morphine are necessary even if you are combining palliative care with your routine work. That's my major point and the reason for showing this diagram. And we will keep on having to tell patients, families, fellow doctors, nurses, everybody. Dependence is not a major problem with cancer because in cancer, the period of pain relief is time dependent, either cure or death. Whereas with chronic non-cancer pain, it can be serious. And we made this point once before. If I did not, let me make this point. Everyone in this group, I would like you to understand that all dependence is not addiction. If following a severe pain state, like a post-operative complication and continued opioid therapy for 2 months or a month and a half, you stop it. You may still have physical dependence. Usually, more than 3 weeks of continuous opioid therapy causes physical dependence. The physical dependence will manifest as withdrawal symptoms on discontinuation of opioids, low energy, sleepiness. But also remember these two, disorientation, delirium, myoclonic jerky movements, are also what you see with opioid toxicity. Remember, similar symptoms happen on withdrawal also. And a particular feature, a frequent feature of withdrawal is abdominal cramps and diarrhea. So, if you are using morphine or another opioid, even tramadol, in somebody on a regular basis for more than 3 weeks, be warned. Withdrawal symptoms may not happen, but may happen and can be very debilitating. Therefore, withdraw them gradually. Slow withdrawal. Reduce to 1/3 the dose. Wait for a week. Reduce to further half. So gradually withdraw. So that is withdrawal symptoms only mean physical dependence. He is not addicted. Addiction is psychological dependence, manifesting as craving for the substance. Increasing dose requirement as time goes on. Unsanctioned doses taken frequently. Behavioral changes. And these are features of addiction which usually would not happen if you use morphine rationally, meaning titrate it to the degree of pain. That's how you use it, right? If tramadol is not enough, you start with a low dose, maybe 10 milligrams. You titrate. If necessary, you increase a little more. The quantity of morphine that you use is titrated to pain relief. With that kind of titration, addiction is rare. I did not say that addiction is impossible. I said it is rare. I said it is not a problem with cancer, but I will warn you, if you have to use it for non-cancer pains over the long term, then be mindful of the possibility of addiction. Some precautions will have to be taken, which we talked about a few weeks back. I'm pausing a little bit to take on any question that you have on the matter so far.
So in chronic conditions, non-cancer conditions like TAO and all that, when you start morphine, the likelihood of getting addicted, I mean, overusage of morphine nowadays very frequent, I have seen. Because those people used to be addicted to tobacco or even some other drugs and all. So they won't stick to our dosage. And, can you hear me, sir?
Yeah, I can hear you, Dr. Ravi. Dr. Ravi, thank you very much for the question. Very important question. And you brought in a condition, thromboangiitis obliterans, a vascular kind of pain, which is one of the worst kinds of pain. If you bring me two things, TAO and cancer, and ask me to choose, I will choose cancer. Because the pain from ischemia is one of the worst kinds of pain in the world. I have seen people attempting suicide. I mean, I've seen people with scars, and that happens more often in TAO than in cancer, very much more. So, Dr. Ravi, that person deserves pain relief. Now, morphine by itself may not be enough. In mass ischemic pains, whatever you do, unless you practically anesthetize the person with a spinal anesthesia, the pain relief will be incomplete. But at least partial enough pain relief will make it possible for the person to live. So you brought in this example. The pain being so bad and it being our duty to relieve pain, this is a person in whom I will use morphine. I will use it along with drugs for neuropathic pain because in ischemic pains, invariably, there is loss of blood supply to the nerves also. Vasa nervorum are also ischemic. So a vascular neuropathy component is there. We will use judicious use of NSAIDs, morphine, and adjuvants. So, is there a possibility of addiction? You bet. What is going to happen to the limb? It will either be amputated or he is going to die most of the time. Once in a way, with various measures, you may be able to relieve the pain and save the limb partially. Of course, if it is surgery, then there is no question. If it's a major vessel disease and removal of a clot takes care of the problem, that's another case altogether. But if it's a long-term pain, this is a patient in whom I will insist on using morphine, mindful of the possibility of addiction. But Dr. Ravindran, let me make it more difficult. Your question was too simple for me. A little more difficult. Very severe low back pain. No correctable surgical solution, but intense pain. That happens. That happens without a definable anatomical abnormality. The only thing that relieves his pain is morphine. What do you do? Nothing else seems to work. So what I would do is, there will be these people. There will be a proportion of patients with non-cancer pain who will need opioids for pain relief. So I think we mentioned it once before. I'll repeat that. In these people, we have a frank discussion with the patient and family. Look, nothing else has worked. In him, opioids are relieving the pain. But here, there is a potential problem of the person, you getting addiction. We will do it only if there is no other choice. In your case, it appears that there is no other choice. So the patient may not want to do it, family may not want to do it. 2 weeks later, they will come, nothing is helping. I can't live like this, please, let us proceed. And when we do it, we actually write down on the file and have it very clearly told to the patient and family. We are doing this, but there are some conditions. One, you should not increase the dose without my permission. We are working together. No unsanctioned dose escalations. Because if they are getting addicted, the dose requirement will keep climbing up. Dose may climb up because of the disease itself. That's another thing. But no unsanctioned dose escalations. This is the condition. Strict. So if they get addicted, they'll be desperate. They'll come. You have given enough for 2 weeks. They come after 5 days. I'm so sorry, doctor. I've lost the medicine. You go into the history. It's very likely, it's possible that he's correct also. More than once, you will never give extra. You will say, this is our contract. You are going to hate me, but I am promising that I will not give you anymore. There is one risk. The person may travel to the next town and register at another place and get coffee. That's a risk we'll have to accept. But here we are balancing the risk and the Shashikala says, vasculitic pain, scleroderma, oral morphine temporarily, while other medications, etc., etc. Yes, temporarily or even long term. Scleroderma, uh, what we used to call scleroderma, now we call it systemic sclerosis, not to be confused with multiple sclerosis.
Systemic sclerosis, progressive
So it is a very, very painful condition and usually results in the death of the patient eventually. It's a question of time. There is no known cure, no other treatment. Here, very often, an anesthetist may be able to relieve limb pains by sympathectomy. But this is a patient, if necessary, I'll use morphine for life, if necessary. Anju asks, oh no, sorry, I know it asks what is pseudo addiction. Okay, we still have not started on the subject of opioid availability. I realize that Sunil must be mentally giving me angry looks. But let me answer that question and then move on. Important question. This is something that usually happens. Shashi goes on rounds. There is this person with ischemic pain. She has pain. You are on duty in the morning. Evening duty, nobody said, morphine, no, nothing doing. We are not going to give you morphine, but you give morphine. The next day, you go and they are saying, Dr. Kala, please give me that injection. He's clamoring for morphine, and everybody thinks, he has become addicted. He is demanding pain relief. Demand for pain relief should not be confused with addiction. If I mentioned dose escalations. If somebody's cancer gets worse, somebody's ischemic ischemic pain gets worse, their morphine requirement will go up. So pseudo addiction is what you call it when there is an increasing dose requirement because of a clinical problem, or when the patient desperately demands pain relief, that can be mistaken as addiction. So thank you for that, raising those points, though it was possibly not part of the subject for the today. It lays the background. I'm glad we had that chance to talk about it. So Raju, can we have this poll? I know we have talked about it. Still, I am asking the question. Yes or no?
Sorry,
If used for cancer pain management, can oral morphine lead to addiction or not?
sorry, sir, we can't have it right now.
Okay. So the answer is yes, it can. But the correct answer will be yes, but. Yes, but it is not going to be a significant problem. This is the principle of balance, which the scientific community globally has accepted. Dr. Ravindran has said two responsibilities. Dr. Ravindran has the responsibility to prevent abuse of opioids and also to make opioids available for those in pain. We are all enthusiasts in palliative care. We want people to have pain relief. But let us not forget the first responsibility also. Imagine if everybody is given morphine and the drug controller does not insist on the rules being followed, if there are no periodic inspections. Tomorrow, you, Dr. Anuj, will be pained to see a report in the newspapers that so a carton of oral morphine has been stolen and diverted to the market. We don't want that to happen. We want to take adequate precautions. So everybody is clear about the principle of balance. Everybody here is accepting that responsibility, dual responsibility. And for the sake of patients, we need to ensure safe and uninterrupted access to opioids. This is one thing, one responsibility that we all should accept. Because it's not an infrequent thing in the early days. You get morphine, youth are very happy, patients are very happy. And all of a sudden, one day the pharmacy says, we have run out of morphine. Now, this is going to be a huge calamity. Because people who have had pain relief, who have enjoyed pain relief with an intensely painful condition, all of a sudden being told, it is like saving a drowning person from the water and after some time pushing him back again. This is horrendous. So together we will all accept the responsibility to ensure safe and uninterrupted access to opioids in your workplace. We will have to ask, if it doesn't happen, suppose the pharmacy says, we have not run out of stock. Don't start quarreling with them, but sit down there. Don't walk away either. Sit down there. Hey, can I talk to you for a minute? Let us see what happens. Find out why the stock out happens. Take corrective measures. I am telling you, because in the year 1994 and 95, I went through this several times. Stock outs. Those were very, very painful times. I don't want that to see that happening ever in my life again. And of course, we said safe. Documentation ensures safety. If documentation is compromised, safety is compromised. If you find that at the end of the day, hey, the stock register does not tally, 50 tablets missing. Okay. Against the name of Gopal, write, instead of we had written on 10 tablets, write it on 60. Make book adjustments. Nobody will know. Nobody will know. But 50 tablets, if they disappeared, it can be lying at the bottom of the shelf. But if it has been stolen, it may find its way to the black market. And the person who steals 50 will steal 500 tomorrow. Let us not underestimate the importance of this. Never, ever compromise. What we do is, if 50 is lost, we institute a thorough inquiry. We will not permit doctoring on the records. We will institute a thorough inquiry, and when a thorough inquiry is done, usually it reappears. But we also have the responsibility to continue to advocate for pain relief. One of the problems that you are going to face, I can predict, Dr. Molly Thomas. Dr. Molly Thomas, where do you work?
Sir.
Sorry?
Harbatpur.
Harbatpur in which state? Sorry for my poor geography.
Sorry, Uttarakhand.
Uttarakhand. Okay. One of the problems that you will find is that your colleagues will criticize you. See, in COVID, there is a big role for steroids. Sorry, of course, big role for opioids, especially when patients are in agonizing pain or when they are breathless. So one of the doctors who did one of our courses, Dr. Pradeep Kumar, I think he was in Himachal Pradesh, right, Raju? So Dr. Pradeep used morphine to relieve the breathlessness of a patient. The nurses and the doctors were horrified. So we worked with him. Gradually, people were to understand. You will show them Oxford textbook of palliative medicine. You will show them evidence saying why this is an ethical imperative and not something to be done away with. This is going to be hard, but don't give up. On behalf of this man and 1.5 million people in pain, we have the responsibility to keep advocating. Now we come to procurement of opioids. The book was the NDPS Act of India of 1985. You can see how huge this is. One law book. Extremely complicated law and rules. This this was brought in 1985, and in February 2014, after 19 years of efforts, Indian Parliament changed the law. I'm not necessarily going to talk over a lot about the complications that were there earlier. So I'll show you the distinction, because I know that in many states, the old rules are still followed. The old rule meant that to obtain the morphine or methadone or fentanyl, you needed multiple licenses. In almost every state except Maharashtra. In Maharashtra, even in the old rule, you only had to go to FDA. In every other state, you had to go to excise, you had to go to drug controller, and then in many places, director of health service, etc. Multiple government agencies were involved in the licensing process. You will think import and permit is only from other countries. No. Import and export talked about bringing it across state borders. A hangover from British India. And permits usually had short validity periods. One of the problems I found in 1994, that with a lot of difficulty, I got a possession license. I then found that I had to apply for an import permit. By the time I got the import permit, possession license had expired validity. So these problems occur. Export permit is for the manufacturer to send it from his state. Now this rule is no longer valid from 2015. 1 year after the act was passed, this has become invalid. But strangely, in our country, these things happen. In many states still follow an illegal process of this complication. So this is, doctors, this is one thing that we may have to change. In Uttarakhand, this has changed in 2019. Till 2019, it was a complication. For the first time, Ganga Prem Hospice became a recognized medical institution. I'll explain what that means. According to the new law, 2015, the states cannot have its own laws. The whole country has own law. And according to the law, the law created a class of medicines called essential narcotic drugs. ENDs is what it is called in the law book. Narcotic is not a scientific name. Opioid is a scientific name. But this is what is there in the law. Everybody, I hope the message is clear. According to the new law, there is a class of medicines called ENDs. Morphine, fentanyl, and methadone come into this class. Recognized medical institutions or RMIs approved by state drugs controller do not need these licenses. No licenses are necessary. So, Dr. Shanti, where do you work?
Hello, sir.
Where do you work?
Medical College, Kottayam.
Kottayam Medical College would be an RMI. I asked the wrong person. Its morphine should be already available there. You would not have a problem. Dr. Jocelyn Esther, where do you work?
I work in Maharashtra, sir.
Where
It's near Nagpur, a rural village.
do you
Umri.
have access to morphine?
Right now, no.
So, what Dr. Jocelyn, you will have to do, we are going to talk about the formalities. Your institution, are you with Emmanuel Hospital Association?
No, sir. It is a separate hospital. It belongs to Free Methodist Mission.
Your hospital, what's its name, Dr. Jocelyn?
Umri Christian Hospital, sir.
What Christian hospital?
Umri Christian Hospital.
Umri Christian Hospital will now apply for approval as a recognized medical institution to the state drugs controller. In Maharashtra, the state drugs controller is called the FDA, Food and Drug Administrator.
Okay.
So what you will have to do, I'll show you the Form 6 section. Apply to the drugs controller for approval as an RMI.
Okay.
If there are problems, we will work with you. Just as we worked with Ganga Prem Hospice over a year when they had problems, that was in Uttarakhand, we will work with you to make it happen.
Sure, sir.
And this is not I just called Dr. Jocelyn's name, that's all. This holds true for Dr. Ranjit Thomas Rajan and Sneha Yadav and everybody in this group. Aarti, if your institution is not a recognized medical institution, you will have to become one. Once you have got the status, it is valid for 3 years, and you do not need any more licenses. You just apply, you just place an order with the manufacturer, pay the money, you get the medicine. Now, before I go on to that act and rules, any questions so far? Please unmute and speak or write in the chat box.
Sir, good afternoon. It's Bipin from Jharkhand.
Yes, Dr. Levin.
Dr. Bipin, sir, I'm currently working in a community health center in the public sector, and I hold a private OPD clinic in the free time in between. Usually in the morning, early morning, and sometimes in the evening. Though our community health center is registered under the Clinical Establishment Act, but my OPD, because it's sometimes 2 patients, sometimes 4 patients kind of, so it's not registered per se in the Clinical Establishment Act yet so far. We are planning to get done, but can a clinician independently apply for that NDPS act, for morphine or these drugs?
Thank you for the question. There are 2 possibilities. One, if your clinic is an official clinic, it can be an institution. It doesn't have to be a government institution. It doesn't have to be a hospital. A clinic. Doctor, I did not quite catch your name. How do you pronounce that?
Bipin, Bipin.
Dr. Bipin, So if you have a clinic by name Dr. Bipin's clinic or something like that, that clinic can also apply if it's an official clinic. If you are a private practitioner with your own practice, this institute cannot be called an institution. There is a provision for registered medical practitioners to have a small supply for your personal practice, but that is more complicated. Today, I'm not talking about that, but Dr. Bibin, if you want to get that license as a registered medical practitioner, there is a process. We are not talking about it today, but I can work with you on this. But remember, the quantity that you can keep as an individual is very limited. As an institution, there is no limit. You order and keep as much as you need. But as an individual, you can keep only a very limited amount of drug. Thank you for the question, Dr. Bipin. I can work with you on that later.
Sir,
Just email me.
sure, sir.
Anybody else?
So this is Jürgen here, sir.
Sorry.
So this is Dr. Jürgen. I'm actually working as part of the Emmanuel Hospital Association in Bihar, in
Okay.
a place called Madhepura, as a medical officer. So if I were to apply for licensing for narcotic drugs, I would have to follow the same procedure as you had mentioned, sir, to Jocelyn?
Yes.
Okay, sir.
So in EHA, many institutions have already become RMIs. So the process will be known to EHA. But by all means, we will work with you on getting the RMI status. Your institution or hospital must get registered as an RMI. I am not aware of the rules having been followed yet in Bihar. So there could be problems, but then problems are there to be overcome. I'm not sure that Bihar has implemented the new rules. I'm actually looking for an opportunity to make sure that it does get established. And doctors and partner will help us.
Okay, sir. Thank you.
So Molly here. Will you be telling us what the requirements would be for the RMI?
Yes, I'm going to talk about it now.
Okay,
Thank you. One thing that I'm sorry to bore you with these minor details, but you need to understand the difference between an act and the rules. Narcotic Amendment Act is a law that is passed by the parliament, or if it is a state, by the assembly. In this case, assembly no longer has the power to legislate. Rules are created by an official order by an executive officer, the district collector, health secretary, anybody, drug controller. They can establish rules with the permission of the government department. So you understand the difference. The government passed the act, the parliament passed the act, saying that recognized medical institutions can keep, stock and dispense essential narcotic drugs or ENDs. So that's the law. The rules that were announced in 2015, 2014 was the law, 2015 the rules came out. Said that morphine, fentanyl and methadone are essential narcotic drugs. The importance is, tomorrow, if you feel something else has to be included as an essential narcotic drug, you don't have to go to the parliament. The Department of Revenue of Government of India can pass an act and get it done. So according to the rules, to stock and dispense essential narcotic drugs, these three medicines, any institution has to become an RMI, recognized medical institution. So really, those who follow the old licensing process are doing something against the law of the land. But these things happen in our country. So as Dr. Molly asked, it's important, if you want morphine, fentanyl or methadone for the future, it's important to know how to become an RMI. What do you need? Only conditions. You need a doctor, MBBS or BDS. BDS is allowed because dental institutions, maxillofacial surgery departments, etc. can also use them. The only condition that the rules have put in is that the doctor should have a training in pain management. The government of India's rules has not defined what this training is. I expect that in 2025, when the medical students who join medical studies in 2019 become qualified doctors, they will not need any other additional training because their curriculum included training in pain management. But for you and I, for Dr. Annie Mary and for Dr. Vasu Prakash and for me, our curricula did not include training in pain management. And unfortunately, paradoxically, imagine doctors qualifying without learning how to treat pain, but that happened in our country. So this training has to happen. And in Kerala, online training is approved for RMI status. So in this group, Raju, I expect in a couple of weeks, will be sending you a certificate of training. You can enclose that with a copy of that and apply to the Kerala State Drug Controller, and you can get your RMI status. But for other states, there is no rule yet. Therefore, you will have to apply anyway. They should be able to give it to you because the training has not, the nature of training has not been defined in the rules. Here, you can just say that the rules say training and I have had training in pain management. And we'll work with you. We'll try to persuade the drug controller. But what I'm saying is, as it stands today, it will be up to the drugs controller. For Dr. Bipin, it will be up to the drug controller of the Jharkhand to decide. Strange, isn't it? They will decide whether your training is adequate or not. Usually they do not know. So if you give a certificate, they accept. I'll talk more about the process of application, etc. But any question about this?
None, sir.
Somebody spoke, I could not hear.
No questions, sir.
The doctor was saying no, nothing. You can continue.
Okay. Thank you, doctor. And thank you, Raju. So, Dr. Molly Thomas asked, how do we apply? So here are a few things to be done. The head of the institution, for Dr. Shashigala, it's either you or your husband makes the application. And understandably, you write a covering letter to the drugs controller of such and such a state. Sir, madam, for treating pain, we wish to stock and dispense essential narcotic drugs. I have Dr. So and so in our department. Our institution has had training in pain management, the certificates enclosed. Please send your approval as an RMI. You say that. But most importantly, please start a file. A file is very important because you will need this. In many states, the response will not come. You need the evidence. Even if the drug controller's office on your way to work, you will think I'll drop it personally there. I would recommend don't. Send it by registered post. in your file along with the application, staple the receipt so that you have proof of sending. Because the drugs controller is legally obliged to respond to you within 2 months, either giving permission, giving approval, or rejecting it, showing a reason. He or she cannot reject it without showing a reason. And as I said, in 2019, when Ganga Prem's Hospice's application was not sanctioned, they wrote up asking for something and something, including Clinical Establishment Act. Doctor, I have forgotten who mentioned Clinical Establishment Act. That is not necessary. Legally, registration under Clinical Establishment Act is not necessary for an RMI status. So if they say that you produce this thing, Ganga Prem Hospice responded by saying that according to the law, that is not necessary. These are the requirements we have given it. That was given by registered post. Of course, I also wrote on behalf of WHO Collaborating Center saying that this is the law of the land. This is what should be done. And they got the RMI status. So initially there could be problems. So covering letter, you have to show that you have a genuine institution. How do you do that? In every state, there will be state-wise rules for registering healthcare institutions. In Kerala, it is locally with the local self-government institution. It's very likely, Dr. Sachikala, that your clinic is registered with the Kochi Corporation.
Yes, sir, it is. It is registered and renewed.
Right.
Yeah, it is registered, sir.
Yeah. So you will better enclose a copy. The law doesn't say that. If you don't enclose it, they will ask, hey, what kind of place are you? We don't know. So better enclose a copy of that. You may be a registered trust or a charitable society. Include the bylaws. In many states, in Delhi, for example, you have to register with the registrar of nursing homes. That's a department to which you write. So, to which you have applied. So that document showing the genuineness of your institution, it's better to attach it. Otherwise, the file will keep coming back and forth. The degree certificate of the Dr. Vasu Prakash, when you apply, your MBBS degree certificate should be attached. Better include your MBBS. If you give your MD certificate, they may ask you where is your MBBS certificate. This is again their discretion. Better include your registration certificate. Registration with the medical council or dental council. Enclose a copy of this and enclose the certificate that our Raju will be sending you, showing that you have had training in pain management. And these are the things to be sent. I am pausing for a minute for you to take in this information and ask any question.
Do they have any prescribed form or something that we should download and fill along with this, or we just have to?
We are going to show you in a minute. There is no form for the covering letter. No particular forms. These are things that you already have. You enclose a copy. But other forms I am going to show you in a moment. Thank you for that perceptive question.
So, what about this enclosed document if I'm from Mumbai, sir, like this trust deed or commercial license?
What document?
The second point, so the trust deed or commercial license. Where do I apply? How do?
Doctor, who is asking the question?
Dr. Sheila, sir. Sheila.
Where do you work?
Sir, Mumbai, sir.
No. Which institution?
So I have a private clinic, sir. My own. I'm a private practitioner, sir.
Your clinic.
Yes.
Is it registered with the Mumbai Corporation or
No,
whatever?
Sir.
No registration.
No, sir.
Doctor, then that will be difficult.
Okay.
You have to be an institution to get this status. So the best thing will be your clinic, whatever you have, there would be a process of registration with the local self-government institution, possibly.
Okay.
I
Right,
don't know
right.
about Mumbai. There must be some kind of registration within the state. In some states, it is the state health department. As I said, in Kerala, it's with the local body. It's very likely to be in Mumbai administration. So Raju, please make a note of it. Somebody like Dr. Raj may be able to answer that question for us. Who should they register with?
Okay, so then I may ask Dr. Rajam. Initially, 2 days back, I had a chat with her.
Okay, okay. Very good.
So I'll ask her, no problem, sir.
Yeah.
I'll get her.
Thanks. Okay.
Thank you, sir.
Thank you. Okay, all the forms are given in our website, but nevertheless, Raju is going to show you some other forms. There is also this document. Raju, you will be sharing this presentation with them, right?
Yes, sir.
Yes. So I would strongly recommend that you should look at this document that Dr. Nandini Vallat prepared, best practices for using step 3 opioids. That will tell you like what all precautions take, how to keep the documentation, etc., etc. Raju, shall I stop? I'll come back to the screen sharing later if necessary. But you want to show the form for application? Okay, that's a list of the forms. Yeah, this is intimidating. If everybody sees this long list. No, all the forms are not for you. Some of the forms for the drug controller to keep. Raju, wait, scroll up. Wait. Okay, scroll down. I'll tell you where to stop. Wait. No, not needed. Go on. Not needed now. No, go on. That's for the sender. We'll have to come back to this. Raju, please make a note of this. Form 3D is something that we'll have to come back. This also we'll have to come back. 3D and E, no? Whatever. We'll come back to that. 3D. Here it is. So this form, I can never remember the number, 3F. Raju, can you blow it up a little, zoom in a little bit? Very good. Very good. Thank you, Raju. So, doctors, you have to know how to fill this. But nothing complicated, not because it's complicated, but when you go back and try to do things, some doubts may happen. Of course, the first one is very clear, right? Name and address, phone number, email ID, etc. It also talks about fax, but who has fax now? Now, it says relevant supporting documents to be attached. Remember the several documents that I mentioned earlier, including your certificates, the institution's registration, etc. Name on the head director or medical superintendent or whoever the institution. The 3, just okay, fill something in. Nobody is going to check. How many people are there? Doctors. Shashikala will write 2 doctors. Nursing staff 2. Others 3. That's enough. Not important. For a huge hospital, it may be 220 doctors and 1,590 nurses. Whatever that is, you put that in. Number of patients treated during the previous calendar year. Nobody is going to come and check whether the numbers are very accurate. So whatever is available, you put in. But what if you are a new applicant, new hospital, new clinic? You say new institution. That's enough. Just write their new institution. And if it's only a clinic doing only outpatients, just give the number of outpatients and say nil for inpatients, nil for home care. Better put in nil, otherwise they will ask a query, how many inpatients? So in the case of category, you just say palliative care. The others do not apply. I'm not going to explain the others. You do not apply, say palliative care. You are the qualified medical practitioner, doctor, every one of you. You put in your name under column, row 5. Say that you have had training in pain management, palliative care, such and such, copy enclosed, attach the certificate. Suppose there are several doctors, you can give several names in the column, in the row 6. No. Indicate the name of the medical practitioner, that's you. If there are 5 doctors who are trained in using it, they all can prescribe it, but your name still goes up as the doctor in charge. If it is a renewal application, then only 7 applies. If not, just write new application. 8 is obvious. May not apply to you. Okay. Raju, keep it there while I take questions on this form. Okay, Raju, go down. That's not for you, that's for the drugs controller. He sends a certificate of recognition or sends you a rejection showing why it has been rejected. And we can appeal. Next, please. Now, ladies and gentlemen, here is a form given for daily accounts. Sorry to give you this news, but it is our responsibility. Remember, principle of balance. We have the responsibility to ensure safe documentation. Every single patient's name and the quantity dispensed, etc., has to be documented. No way of getting around it. This has to be done. But we don't keep it one form for every patient. Raju is going to show you how we do it. Raju, that copy of the register, please. So can you zoom it in a little more, Raju? Yeah, okay. So the first few columns are for enter. What is shown in red is for entering receipt. Say on that date, a quantity of 26,000 tablets were received. That must be for a particular strength. We have separate registers for 10 milligram, 20 milligram, 50 milligrams, etc. morphine. We have a separate register for fentanyl injection, separate register for fentanyl transdermal, etc. Avoids confusion. So the first few columns are for receipt. If you have received it, you say from whom. The third column says from Lisi Hospital Pharmaceuticals, quantity, date, etc. And then you have the date, patients, the start opening stock, the patient's name, the quantity dispensed, and towards the end, after each administration, how much is given out, how much is left also is written. Raju, something is wrong, Raju. I'm sorry, I don't know how I missed it. Where is the name of the patient?
So we have deleted all.
In confidentiality. Oh, thank you, thank you. Sorry. Just be mindful that this is not left blank. Raju, being a very ethical person, deliberately deleted it because ethically confidentiality has to be preserved. Patients' names are not to be shared. Very thoughtful of you. But the patient's name, registration number, name, age, registration number, etc. are entered here. So for each patient, the date is entered, quantity dispensed is entered, and the quantity left over is entered. In Palim, India, I am the doctor registered whose name is given as the doctor in charge. I don't actually dispense it personally, but I have the responsibility to make sure that the stocks are checked periodically and I sign periodically. That's a register. Can we go back to the forms, Raju? So this form JH, sorry, 3H is something that we put in the form of a register, not one per. You can do it this way also, but imagine at the end of the year, you will have such a lot of wasted paper. So we use registers. Register also make sure that it's easy to check. If there are disparities in the numbers, that's easily found, and so on. Raju, is there any more form there? Oh, this is a form that you have to submit once a year. At the end of the year, I mean, actually, I think it is supposed to be given in January. I forgot. We'll check. You submit a form showing how much you have used over the year. How much have you ordered? How much have you procured? How much have you used? This is to be sent to the state drugs controller. And along with that, you also submit an estimate of the annual requirement to the drug controller so that the drug controller knows how much institutions need. So what I usually do is, if last year we say our consumption, Sunil, it is something like between 4 to 5 kilograms, right? We usually
Yes, sir.
put in 20% more and submit it as the annual estimate. Suppose your clinic becomes very popular. I usually say for any new institution, just say annual requirement is half a kilogram. You have to write something there. And suppose you find that your clinic is very popular and after 8 months you have used up the half kilo, you want more. You can always submit an additional requirement. There's no problem. Extra estimate can be submitted. You don't have to wait for approval. Once you are in RMA, you can order for more. Only things you must inform the drug control. All that may sound complicated. It is not. We will help you with when you have questions. Next, please. Okay. Raju, go back. Stop. What was that? No, previous one. And the one previous to this. No, previous. This is the consignment note, not the previous, the one before that also. Go back to. No, that is not it. I missed something. Go down again. Sorry, there, ladies and gentlemen. Wait. Consignment note. Daily accounts. This is what we put in the register. There is a form in which you apply or place the order, Raju. That's what I'm looking for. No. Maybe it's in the beginning, Raju. Sorry. Not this, not this. Not this. Not this. Maybe we'll go through the whole thing once more. No. 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 Is there anything more, Raju, after this letter of the government order?
Sir,
No,
is
no.
it the consignment note you are mentioning?
Yes.
This one?
No, no. No. There is nothing. About this appendix 1. That's the RMP thing. Yeah? Anyway, okay, sorry. I'll verify that and let you know. There is a form in which you place the order and send it to the manufacturer. We will, depending on the state, we'll have to check who is most likely to give you. We'll have to check the cost of various manufacturers, and you will have to place an order. Before I go on, there are a lot of questions on the chat box. Chetan, the RMI certificate is valid for 3 years, but before conclusion of the 3 years, we apply for a renewal. Methadone fentanyl patch and methadone can be bought using the same RMI certificate. You don't need any special recognition. Shashi, is it possible that you are doing you have an RMI status? Have you got a certificate of approval as an RMI?
Yes.
Yes, you can order fentanyl patch and methadone with this. That's what we do also. And you don't run after excise for any more certificates. Injection fentanyl also can be bought with this. Anything else? Scroll down, Raju. Any other chat question that I have missed?
No, I guess, sir. Dr. Sunil have given the answers to.
Oh, very good. Thank you, Sunil. So, the form of application was explained. You apply in that form by registered post, keep a copy in your file. You read the best practices, please. Nandini's file, that's a simple, nice document. Once recognition as RMI is obtained, you place the order with the supplier. There is this clause in the law. Government hospitals are deemed RMIs and do not require a certificate, but you are also still required to submit the annual requirement and annual requirement and the statistics every year. The problem is, even though the law says government hospitals are deemed RMIs, you don't need a certificate. Most drug controllers do not know this. So if you apply, they may still ask for a clarification from drugs controller. Drugs controllers themselves may not know in many states. So there can be some confusion which we'll have to sort out. Sunil, I see that we have only 5 minutes. Back to you for any comments or taking questions.
Sir, how long did it take to get the permission for the hospice in Uttarakhand?
It would have taken 4 or 5 months because initially they objected. Within 2 months, they wrote back asking for more documents. And then we had to write. But once we wrote registered post, it came within a week. So I don't exactly remember. But even if it cannot be more than 4 or 5 months.
Okay.
And because that was clarified once, hopefully, next time in Uttarakhand, it will be easier.
Okay. Thank you. Thank you.
Thank you, Goli.
So another just a doubt. Like in a medical college, even though many departments use morphine, there will be only one point person to keep this registry and get the drugs from the thing, or
Yes. Yes,
only
Dr.
one point person.
Murali, in a medical college, one person will have to be designated as the doctor in charge. Understandably, the pharmacy will keep it, but this doctor will have to keep some kind of connection with the pharmacy to make sure that the stocks are not run out and the documentation is okay. So in large institutions, when a new system comes in, there usually need to be some clarifications. And understandably, if your hospital director or medical superintendent is cooperative, things become very easy.
Okay. So the different departments can take it from the store,
Yes.
from the pharmacy.
Yes.
Okay. Thank you.
Dr. Angela Vishwasam asks, will this certificate suffice for us to practice in an existing palliative clinic? Doctor, you don't need any certificate to practice in an existing palliative care clinic. That is not mandated. Anybody can. Only thing is, if you are trained, you are supposed to include your name also in the annual, in the request to the trust controller. But that's no problem. People keep coming and joining our department with Sunil, and they practice. We don't need any extra certification.
So, if my clinic is not registered as RMI, so till I get registered, will my prescription be, can a patient procure morphine from an institute on my prescriptions basis, sir, or no? Is that valid?
Sheila, you are in UP.
Mumbai, sir. Mumbai, sir.
As far as I know, it is not possible.
Not
There are
possible.
some cities like in Delhi, Hyderabad, Ahmedabad, maybe in Maharashtra, I'm not sure. In some states, the drugs controller has given certificate for some pharmacies to stock and dispense morphine. And
Okay.
there, that particular pharmacy will check the prescriptions to see if it's in order and then give it. But as far as I know, in Maharashtra, private pharmacies are not stocking this. If you send a certificate to a Tata Memorial Hospital, they will not honor it. They wouldn't want to take the responsibility.
Okay, okay.
Any more questions?
There will still be doubts as we go along. So do please feel free to contact us.
So, sir, we have to take their feedback also now.
Yes, please go ahead.